Welcome to Primary Care Conversations with Christine and Jeff, providing valuable and engaging pearls of wisdom on a broad range of topics relevant to your practice. Now join your hosts, Dr. Christine Palmay and Dr. Jeffrey Habert, as they guide you through the ever-evolving world of primary care.
Okay, welcome back, everyone. Hello, Christine. How are you today?
I am dandy. How are you, Jeff?
I'm well, and I'm happy to see you. So today is the hotly awaited for part 2 of our menopause series, and people have been asking, when is Christine going to do part 2? And today is the day. So today we're going to focus on systemic therapies, and let's give the theoretical case. So the 53-year-old woman comes in. She stopped having periods 14 months ago. She is very uncomfortable having 20 to 30 hot flashes a day, but she doesn't really want to take anything because she heard that they're quite dangerous.
Yeah, I'm going to put a pause on that and do a bit of a prelude. So hopefully we've had discussions with this lovely woman at least 10 years beforehand, okay? So menopause treatment, and I'm going to be very, very careful in wording. We no longer say HRT. We say menopause treatment because we have some new options on the market that are non-hormonal. So menopause treatment is having a heyday right now. It is the renaissance, after a very long time period of women truthfully being denied therapies for a myriad of reasons. After the Women's Health Initiative, certainly there was fear amongst the medical community. There was certainly fear mongering in the media targeted to patients. Hormone replacement therapy at that time was considered to be a big no. Medicine had made egregious mistakes. And as a result, for a decade and a bit after that, individuals like myself never got formal treatment in menopause therapy. In fact, when I was, I think, a first-year resident, or maybe a final year medical student, I'm dating myself, it was my job during my gynecology rotation to call women and say, come off of your hormones, they're not safe. So you can imagine I had 0 hours, 0 minutes of any training. I think that's pretty much the sentiment, in grads that are of my vintage. And certainly, from a medical perspective, the medical community put their hands up and said, absolutely not. So unfortunately, women have been left without options, and that has since changed. As anything else that, pendulum swings too far one way or the other, it's not a good thing, but now we have options that are available. So when I counsel patients, let's say, this woman, she comes to you for the first time, you never had a discussion with this about transitioning into menopause with her before. Hard to believe because, Jeff, you are a wonderful doctor. But nonetheless, when I explain to patients, I say menopause is a moment in time. Menopause is the moment you realize that you have lost your period for a year. The period after that is postmenopause, often called menopause. And, it's relatively hormonally easy to understand. Your estrogen is going one way, down. It's the time beforehand, that perimenopausal period. You are riding a hormonal bronco. Hormones are up and down, left, right, and center. And that's a little bit more challenging. We'll touch a bit upon that now. But, patients come in, it's been 14 months, she's 53. I think some really important points are she's definitely menopause, postmenopausal. She's lost her period for more than a year. She's early in menopause. And in terms of starting menopause treatment, particularly hormonal treatment, it's very important we catch women within the first decade, if not sooner, because the risks versus the benefits after that aren't favorable. So she's 53, she comes in, she's early, she wants help. What are we going to ask her, Jeff?
I mean, we're gonna make sure there's no contraindications. Is there any personal? Is there any family history of breast cancer? Is there a history of VTE? What are her particular concerns about hormones? Like, I want to know specifically because we got a 9-minute visit. So I'm going to counsel as best as I can, and I may bring her back, but I'm going to actually specifically ask her, what has she heard? What is she concerned about?
So she's going to say, well, on Instagram and TikTok, we're talking about natural. I'm going to take my creatine. I'm going to take my bioidentical hormones. I'm going to do my magnesium. And I am not suggesting that lifestyle changes aren't important. I always counsel patients that your medications, if we choose to prescribe them, are not going to lift weights. Very important. They're not going to set boundaries in relationships. Very important. They're not going to help with food and protein. Very important. And there is, a bit of evidence. We won't get into the nitty gritty. Maybe that'll be installment 3 of some supplements. But really, when a patient comes to me and says, I want to do naturally, I want to go bioidentical. Yeah, no. I am much more comfortable giving you prescription grade hormonal, or in some cases, non-hormonal menopause treatment. We'll go over that hopefully soon.
That have years of data.
And that are quality controlled.
Right.
Like, I don't know what goes into your yam cream that was compounded somewhere in the middle of nowhere. So that's the way I counsel patients. And risk factors are quite, so I'm going to include in the resources, the contraindications to birth control are very different than the contraindications to hormonal menopause treatment. They're actually less stringent with menopause hormonal treatment because
the estrogen's a lot less.
Absolutely. So, a woman comes to me and she's been on birth control and she's like, I don't want hormones. Hormones are bad. I'm like, you realize that the hormones that you could potentially take to help your hot flashes, etc., are at a much lower dose. And the nice thing is that we can kind of modify them. So the other thing that she's going to want, Dr. Habert, I want my hormones tested. I want the whole hormone profile.
I love that. And I say, I don't even know what that means.
Well, I'm sure you do, but the answer is, doesn't mean anything aside from 2 conditions. So the only time I am testing estradiol, testosterone, etc., is if I'm starting testosterone therapy. Once again, we'll put that in segment 3. I'm kind of promoting our segment 3. That's going to be taped soon. And also if a patient is not responding, right? Those are the only 2 times that I'm checking hormones. Now, thyroid function, which I sort of put under the, absolutely, you're going to do a basic CBC, you're going to do an ECG, you're going to make sure that there's nothing wonky going on. Maybe her ferritin, particularly if she's not bleeding, but just generally a test panel that I'm recommending, but no place for hormone therapy. People will gladly accept your money in some of these clinics. It's not validated. And unfortunately, there's been a few media things in a noble effort to rally women to advocate for themselves, which I totally agree with. There's kind of this, the pendulum swinging a little too much one way in the public eye right now where everybody needs to be on hormones. And the answer is no, not everybody. Some, when appropriately selected, but some women come to me and look up, they're like, everybody's talking about hormones, but I'm not really bothered. I may have one off, but I'm not, then don't take hormones, right? You still have to go back to basics, though, weightlifting, protein, etc. So she comes to you and, what is her main concern?
I mean, her main concern is she's uncomfortable. She's having 20 to 30 of these hot flashes a day. She's sweating. She's not sleeping. She is not comfortable.
So, and presumably our 53 young patient has a uterus?
She does indeed.
Okay, so our options are to go hormonal, and it's really the estrogen that is going to counteract the hot flashes. And because she has a uterus, we can't give her estrogen to fertilize her endometrium without protecting it with progesterone. And how are we going to do that in terms of hormonal therapy? There are so many options now, right? We can give her a patch and oral progesterone. We can do cyclical, although I have to say, I really like daily. It's just simpler. But regardless, you can give her a ring with estrogen and oral progesterone. We can do a combined oral pill. I mean, I think the rule of thumb now is that we try to avoid systemic estrogen in general because transdermal is considered to be a bit safer. But regardless, we have options. We also have, SERMs. We have medications like Duaviv that are indicated for moderate to severe hot flashes in women with a uterus. So we have options within that hormonal class that can be catered. Does she want a pill to make it simple? Does she not want a pill? Does she like rings? Does she want gels? Does she want a patch? I have many patients who really like Divigel, which comes in a small little patch, particularly for those who travel. You have to speak to her. So it's not only the estrogen, but it's the method of delivery. And right now, we are overwhelmed with options. Or new, as of this year, we have a new class of non-hormonal treatments to treat hot flashes with the added benefit of having sleep benefits. Very exciting, the anti-neurokinin receptor antagonists. Wonderful. We have one available right now, Veozah, put out by Astellas. We will soon have two. Bayer is soon going to have their option available. And these are non-hormonal. So you can think about, say, let's put some contraindications to this woman. Say this woman has had, family history of DVT. She's a bit obese. She has uncontrolled hypertension, right? She's still suffering. And up until recently, you couldn't give her hormones because she was that patient.
So now we have Veozah.
Now we have that.
Yeah.
And
I mean, the other one, just sorry to interrupt for a sec, but so the other one that's considered hormonal or non-hormonal. So you talked about Duaviv. We also have Tibella, which is interesting because Duaviv has estrogen in it, like conjugated estrogen. Yeah. Tibella is a bit odd, right?
But it's an option. And,
yeah, for sure. And it works. They all work. Every single one of these options actually works quite well, and they all fit a particular patient.
Absolutely. So I think that the art of counseling, which obviously takes time, is absolutely essential now because options aren't just based on pharmacotherapy or a mechanism of action, but type of delivery, whether you want hormones or whether you don't, which is new. Our previous episode talked about targeting the localized symptoms of genital urinary syndrome, of menopause or symptoms of menopause. And, for some patients who just have that, we can just give them some topical estrogen or, other variations of that. So really, we have an abundance of option. And my biggest suggestion to the audience is know a few in each class, get familiar. If you are uncomfortable because it's been years since you prescribe it, start with something that is super safe. Your Duaviv is pretty fancy free. It can help to a certain extent, and then you can get fancier. In my clinic, I really like being able to adjust the estrogen combined with the progesterone based on symptoms. And so that's the other point when a patient says, well, why aren't you testing my hormones? Are you being negligent? I'm like, no. Once again, we use symptoms, right? So you have to see these women come in regularly. You have to follow up with them. You have to reassure them, and you have to provide support that this is not going to be the holy grail. We're not going back to hormones being the fountain of youth. We're not going back to menopause has to be treated. We're going to talk to a patient about what her particular experiences are, what her risk factors are, what she wants, what doesn't she want, and cater therapy accordingly. And just like birth control, what I always discuss, just because it ain't broke, you don't fix it. As a woman transitions through life, her risk factors change. And somebody who at 53 didn't have risk factors, maybe at 57 she does. And the other big change is how long do we keep this patient on? The answer is as long as she needs to be, right? There's no more cutoff. There is that suggestion, and rightfully so.
Before 60, right?
Yeah, and we should be checking with patients and actually having these discussions probably when they're in that bronco stage of perimenopause. So, I wanted to take our 53-year-old, let's take her back 8 years. She's 45, she's finished her childbearing. And at that time, she's having bleeding out of control. Her ferritin, it just keeps on dropping. You can't fill her enough with whatever iron option you're doing. You're doing iron infusions. So when I have a discussion with her at 45, so look, let's talk about now. Let's put in an IUD, right? Deal with the bleeding. Let's get your estrogen. Maybe you could put her on a combined oral contraceptive. So Nextstellis has some excellent safety data in that a perimenopausal patient because it's a newer estrogen. It's not ethinyl estradiol, and there's the hope that it has less of a thromboembolic event. But then I tell her what to expect going forward. She's 45, she has a Mirena, it has an indication for up to 8 years for contraceptive. I find that I'm changing them out a little bit earlier for hormonal purposes. So say she comes back at 50, change her IUD, maybe she's in menopause, maybe not, deal with her bleeding, and then I can slap on an estrogen if she's having hot flashes, because the Mirena has an indication for progesterone, right? So you're sort of counseling people at various stages in their life. And that's what I love about this bronco crazy time period in the 40s, because we know what's forthcoming. We know that every woman will transition into menopause in whatever way she experiences that. So prep her.
The other thing we should mention, just to clarify, all these therapies are indicated for vasomotor symptoms, not for
Yeah.
other things. That is the
Correct.
monograph-based indication, vasomotor symptoms. But it's important to say that it will help them. It may help them with insomnia. It may help them with mood. It may help them with libido. So it may help them with bone. It's going to help them with
Bone.
bone protection.
Canada is the only country
Right.
that doesn't have the indication
for bone.
So I call those gifts with purchase.
Right.
Right.
Exactly. But I want our listeners to understand the indication in Canada is
Correct.
for vasomotor symptoms.
Bang on.
All right. That was a whirlwind tour through systemic therapies. Thank you so much. I'm looking forward to our next episode, which is going to be on patients with obesity with a special guest, Dr. Megha Podar. So look forward to seeing you soon.
We have a very special guest coming. So talk soon.
Bye, everybody.